Welcome to this webinar about musculoskeletal ultrasound in podiatry. Thank you for watching. My name is Mark Schmitz. I research and lecture musculoskeletal ultrasound and anatomy at Fontys University of Applied Sciences in Eindhoven, the Netherlands. Next to my university work, I have my own company, KineCare. KineCare teaches both basic and advanced musculoskeletal ultrasound courses to health professionals. KineCare teaches on a regular basis in the Netherlands, Germany, Switzerland and Italy, sometimes also in other countries. The goal of this webinar is giving you a better insight what exactly musculoskeletal ultrasound is, how it relates to other medical imaging techniques, and how it can benefit you in some steps of patient care. This webinar will contain a practical part where I will show you the ultrasound appearance of a variety of anatomical tissues. I will also show you a few ultrasound examples of pathology in the ankle-foot region. Healthcare professionals need to possess more than just their clinical expertise if they are to meet the demands of the changing healthcare system. The use of evidence-based practice may improve healthcare quality, reduce medical errors, help balance known benefits and risks, challenge views based on beliefs rather than evidence, and help to integrate patient preferences into decision-making. In this era of healthcare utilization, healthcare professionals are expected to integrate clinical experience with explicit use of research evidence in order to make clearly informed decisions to help optimize patient well-being. Evidence-based practice requires studying the latest evidence in literature, integrating this evidence in practice, having a self-critical view, and applying clinometrics. Clinometrics is quantifying clinical symptoms and physical signs by applying measurement instruments with sufficient methodological quality. These measurement instruments can have a diagnostic, prognostic, and evaluative goal. A few examples of measurement instruments could be questionnaires, using a goniometer, but also measuring on a structural level with medical imaging. Because of its advantages, its patient friendliness, its technological improvements, and its decreasing price, ultrasound made an impressive growth in several healthcare professions. Here you can see Medicare data about the growth of ultrasound in the US. Can we still use our clinical tests in patient examination? Yes. Please keep on doing these tests, but be aware of the limitations. High-quality research shows that in plenty of cases, the diagnostic accuracy of physical examination we do in musculoskeletal healthcare is limited. The words ultrasound, ultrasonography, and sonography are all synonyms. This webinar is about ultrasound within the musculoskeletal domain. Musculoskeletal ultrasound, in short MSU. MSU is a medical imaging technique used to visualize soft tissue structures in order to capture their size, structure, and function with real-time imaging. In this slide, you can see a MSU scan of the upper leg. In the upper left image, a transverse view of the femur and all 4 quadriceps muscles can be seen. Ultrasound technology is rapidly advancing and being refined and is aimed at both increasing image quality and opening new fields of applications. So what equipment do we need for MSU? First of all, we need a transducer. Transducers come in various shapes and dimensions and are designed for the body parts they have to assess. For MSU, we generally use the straight linear transducers. The transducer is an essential element of the ultrasound equipment, responsible for the generation of an ultrasound beam which is sent into the body and going through various soft tissue layers, like skin, fat, muscle, and tendon. Bone is hard and can't absorb the ultrasound beam, so the bone will reflect this beam. The transducer detects the returning echoes and sends the signal to the ultrasound system, where all information is processed by the software. After processing, the image can be seen on screen. The whole process of sending, receiving, and processing happens so fast that there is no delay. All structures can be scanned and visualized real time. There is a big variety in ultrasound equipment. There is a variation in price, size, and portability, in quality and functionality. Some have a touchscreen. Other systems work as a laptop. Some are more designed for one type of medical field, others more for the musculoskeletal examination. Today we choose to work with this model.
The foot is placed in the end range of dorsiflexion to create a stretch on the Achilles tendon. This enhances the depiction of the tendon. The long, curved, white bright line is the bone of the calcaneus. The Achilles tendon inserts at the calcaneus, and its parallel fibers can be seen horizontally towards the left. We follow the Achilles tendon fibers to proximal. The gray and white horizontal fibers is the Achilles tendon. Note the dark gray and black part in the superficial part of the tendon. This appears to be a zone with less quality, maybe even pathology. A healthy tendon always looks white or light gray. Black indicates a intratendinous swelling. Underneath the Achilles tendon, the soleus muscle can be seen. Do you see the muscle fibers flowing into the Achilles tendon and creating the tendon-muscle junction? At the bottom, just below the soleus muscle, the flexor hallucis longus muscle can be seen. We can activate this muscle a bit by flexing and extending the hallucis manually. The flexor hallucis longus muscle and tendon can also be scanned directly. The transducer is placed slightly medial from the Achilles tendon. Again, the foot is placed in the end range of dorsiflexion to create a stretch on the flexor hallucis. This enhances the depiction of the tissue. At 3.5 cm of depth, we can see a bright white horizontal line. This is the tibial bone. The gray mass just above the tibial bone is the flexor hallucis muscle. At this level, we don't only see the muscle, but already the start of the flexor hallucis tendon. Here, presenting itself as white, horizontal, longitudinal fibers flowing from left to the upper right of the screen. By flexing and extending the hallucis manually, or by instructing the patient to move his hallucis, we can activate the flexor hallucis longus. We sweep the transducer distally towards the medial talocrural joint. At joint level, the flexor hallucis longus has transformed from muscle into tendon. The transducer is placed longitudinal on the calcaneus of the foot to be able to scan the origin of the plantar fascia. The bright white, slightly curved line on the left is the calcaneus. Just above the bony line of the calcaneus, we can see the plantar fascia attachment, presenting itself as a slightly curved longitudinal fiber attaching to the bone. These fibers, the fascia, can be followed horizontally towards the distal foot. Between the plantar fascia and the foot, a dark gray mass can be seen. This dark gray mass is the flexor digitorum brevis muscle. The transducer is placed in a transverse position just dorsally of the medial malleolus to be able to scan the tarsal tunnel with its 3 tendons, muscle, nerve, and arteries. The bright white line going from the left side diagonally down towards the middle of the screen is the tibial bone. To be precisely, it's the medial malleolus. Just above this medial malleolus, in the upper left corner, a dark gray oval shape can be seen. This is the tibialis posterior tendon. The black line around the tibialis posterior tendon is the tendon sheet. Medially, from the tibialis posterior, we can see the flexor digitorum tendon, here situated in the upper left corner of the green box. In the center of the screen, we can see 2 dark veins and the tibial artery. We have switched on to color Doppler mode of the ultrasound system to visualize the blood flow. Slightly right from the tibial artery, just underneath the right green line, the tibial nerve can be seen as a dark gray honeycomb structure. On the right side of the screen, we can see a bright white spot with that dark gray mass below. These are respectively the transverse flexor hallucis tendon and the flexor hallucis muscle belly. At this level, the muscle is starting to diverge from muscle into tendon. See what happens if we flex and extend the hallucis. All structures, the tibialis posterior, flexor digitorum, tibial artery, tibial nerve, and flexor hallucis longus, can be found in the tarsal tunnel. The tunnel is formed by the flexor retinaculum, which can be seen as bright white fibers in the top, starting at the medial malleolus on the left and going horizontally to the right side of the screen. The transducer is placed longitudinal on the talocrural joint. The bright white line going from the left side diagonally down towards the middle of the screen is the tibial bone. Bones can't be penetrated by ultrasound, so the ultrasound will be reflected. Because of this, a black acoustic shadow can be found behind all bones. The bright white line going from the right side diagonally down towards the middle of the screen is the talar bone. Right above the talar bone, you see a thin black line. This is the talar cartilage. The bright, white, triangular shaped structure between the tibia and talus is the talocrural capsule. In the top, you see bright white longitudinal horizontal lines. This is the tibialis anterior tendon. Let's activate the talocrural joint and make a small dorsiflexion. The gliding of the talus in the talocrural joint can be seen. Gel is applied to the transducer to improve the quality of scanning. The transducer is placed on the quadriceps muscle to have a transverse view on all quadriceps muscle bellies. Two quadriceps muscle bellies can be seen, the rectus femoris and the vastus intermedius. Note the bright white epimysium connective tissue sheets surrounding the muscle bellies. In the very depth, you can see a very wide, half-round line. This is the femur shaft. We will sweep the transducer towards the knee. This results in the rectus femoris getting smaller in cross-sectional area. In this position, you can see a smaller rectus femoris, the underlying vastus intermedius, the vastus lateralis on the left, and the vastus medialis on the right. Let's sweep the transducer medially and focus on the vastus medialis. And after this sweep laterally to focus on the vastus lateralis. Can you see the little white fibers inside the muscle? This is endomysium, connective tissue surrounding the muscle fibers. We return to central upper leg to see the rectus femoris again, now a little muscle. The underlying vastus intermedius is still quite big. See the gradual changing of the darker rectus femoris muscle belly into the white quadriceps tendon if we sweep the transducer towards the knee. The white quadriceps tendon can be seen very clearly in the middle, with on each side the darker muscle bellies of the vastus lateralis and medialis, and the vastus intermedius below surrounding the femur shaft.
MSU comes with a high general diagnostic value, equally to MRI. The high diagnostic value of ultrasound is strictly related to a few important criteria. MSU's diagnostic accuracy is not profession dependent, but user dependent. Anybody can do it as long as they fit the criteria described on this slide. But only as long as they use MSU a lot, since there is a long learning curve. This long learning curve goes for every profession. MSU is the preferred imaging technique in extra-articular soft tissue problems. Capsular problems can also be assessed with MSU, but MSU is limited here. Intra-articular structures are hard to assess with MSU. Most of the times it is even impossible. Diagnostic MSU in podiatry is common in several countries. Some countries, however, have rules that prohibit this. These rules should be followed at all times. Still, diagnostic MSU in podiatry can be used for lots of reasons. I will explain a few of these as an example by using pathology images. On this slide, a partial tear of the anterior talofibular ligament can be seen in the left image. The ligament appears to be thickened and hypoechoic, dark, but without total discontinuity. Compare this with the right, normal side, where a beautiful, healthy ligament can be seen. Seeing the exact state of the ligament during diagnostic MSU helps in the clinical decision-making about what exactly to do with this patient. I would always encourage to combine clinical testing and imaging with MSU. It provides much more information. In this slide, the examiner performs an anterior draw test in a patient with a suspected full thickness tear of the anterior talofibular ligament. Instability of the ankle and gapping of the ankle joint can be seen clearly in picture C. MSU changed my view on podiatry. Now I know much better what I can treat and what I can't treat. My success rate has increased enormously because I only treat patients which I can actually help. Knowing one's limitations is important in preventing false positives, false negatives, overloading